Welcome to our webinar titled Long-Term Side Effects of Pediatric Transplant. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question or comment in the small text box window. When you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me monitor and manage the incoming questions. Submit your entire question all at the same time, and please do not share any private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. David Jacobsohn. He is the Division Chief of Blood and Marrow Transplantation at the Children's National Hospital located in Washington, D.C. Prior to joining Children's National, he served as a member of the Stem Cell Transplantation Program staff and as the director of the Chronic Graft-versus-Host Disease Clinic at Children's Memorial Hospital in Chicago. He has lectured widely on GVHD, BMT, in Europe, Latin America, and the United States. He obtained a Bachelor's of Science from Yale University, his medical degree from Tufts University, and a Master's in Clinical Investigation from Johns Hopkins School of Hygiene and Public Health. With that said, it is my pleasure to welcome Dr. Jacobsohn.
Okay, it's really nice to be here today. I'll be spending the next 45 or so minutes talking about late effects of pediatric transplant. And I really want to thank the AAMDSIF Foundation for this invitation. So the objectives today are to understand the late effects of pediatric transplant, understanding the incidence of late effects, how and why they happen, and most importantly, talk about how we can screen to prevent, how we can treat, and how this affects the quality of life and well-being of our dear patients. So on a very positive note, there is an increased number of kids undergoing bone marrow transplantation. There's more indications, especially non-malignant disorders. We can cure diseases such as aplastic anemia, sickle cell disease, and thalassemia, in addition to cancers and immunodeficiencies. There's a lot more availability of donors and stem cell sources than in the past, so we've gotten a lot more comfortable using stem cell sources such as cord blood transplant and haploidentical transplant. And we have better treatment up front, so we are better able to treat infections and graft versus host disease in the early part of transplant, leaving more survivors of transplant, therefore more kids at risk for potential long-term complications. The survival is definitely upwards of 70% in all kids and adolescents undergoing transplant, and this would be higher in patients with non-malignant conditions. The challenges, though, are that the chronic health conditions are high. Almost 2/3 of kids after at 10 years post-transplant have some form of chronic health condition. This is not necessarily debilitating, but these are abnormalities that need to be monitored, and sometimes these can be life-threatening. And there's a lot of challenges. So sometimes we lose patients to follow-up, especially if they live far away. Sometimes there's changes to healthcare coverage, making more difficult for patients to follow up. And as in any other condition, adolescent and young adults are at even higher risk for falling through the cracks. When we look at what happens in the long term after transplant, the most common cause of mortality would be recurrent disease. So this would be a relapse, specifically in patients with leukemia. But then there's other complications that can exist, such as graft versus host disease, or infection, or issues with other organs. So why do late effects occur? It is a combination of many things. It's a combination of the diagnosis for which the child went to transplant. It's also affected by all of the therapy the child received before coming to transplant, the intensity of therapy used for transplant, and then there's another other host of issues that are often beyond our control, like the age of the patient, the age of the donor. Higher age means more risk of graft versus host disease. So one of the main complications that we like to keep an eye on is chronic graft versus host disease, which typically occurs about 3 months after transplant and can be associated with skin rashes, specifically scleroderma, meaning very sort of tight and shiny skin, can be associated with GI issues such as malabsorption and weight loss. And there's also a possibility of other organ involvement such as mouth or eyes. These are some of the risk factors. So kids that are older recipients, donors that are older, those would give you a higher risk of a chronic GVHD in the patient. The most important risk factor, though, for the development of chronic GVHD is if there was a very high degree of a mismatch. So a more mismatched transplant will give us a higher risk of chronic GVHD in the recipient. And this was a study we did almost 10 years back in pediatric patients with chronic GVHD, showing what, on the bottom right, what is the overall survival in kids diagnosed with chronic GVHD. So it is about 60%, about 5 years out from a transplant. And we also looked at what are some of the issues that confer that risk. And they're listed here, such as low performance score and low platelet count. This is a nice single diagram of all of the different issues that chronic GVHD can occur with chronic graft versus host disease. Some patients have very mild manifestations of chronic GVHD, like an oral ulcer or dry eyes, whereas occasionally, maybe once a year or once every other year, you can see patients with very severe chronic GVHD with a number of these manifestations. And typically these patients are very difficult to treat. And these would be some of the pictures. So let's talk a little bit about the immune system. It takes a number of months, sometimes longer than that, for the immune system to recover after a bone marrow transplant. Chronic graft versus host disease and therapy for chronic graft versus host disease can be one of the reasons for delayed immune reconstitution. And if patients have received antibody therapy at the time of transplant, such as ATG or Campath, this can also lead to delayed immune reconstitution. And we can see it here in a graphic that it can take really a number of years for all of the components of the immune system to normalize after transplant. And basically what this means is that at different phases post-transplant, the patient can be susceptible to different types of infections. We're not going to get into it, the very specific details, but we need to be cognizant that there can be infections with bacteria or viral reactivations or fungal infections. Thankfully, we're able to recognize these potential infections very early on, and for the most part, we're doing an excellent job in either preventing them entirely or treating them pretty early. One thing that's important to know is that every patient that receives a bone marrow transplant is basically like a baby with their immune system after transplant, so they will need a full revaccination post-transplant, as listed here. And we typically have certain rules as to when we can start revaccination. For the most part, 1 to 2 years post-transplant if patients are doing well, if they're off their immunosuppression and most of their immune system has started to come back, we can start revaccinating. The problem with doing it too early is that patients may not have enough of an immune system to mount a response. In terms of bacterial infections, we use a number of different prophylactic or preventative antibiotics for about the first year after transplant. So very commonly, patients will take a medicine called Bactrim on either 2 or 3 times a week to prevent something called PCP pneumonia. And very frequently, patients, especially if they have chronic GVHD, will take penicillin to prevent pneumococcal or strep infection. Hypogammaglobulinemia, this means that many times patients are not producing enough IgG or immunoglobulin, and this is helpful in preventing from bacterial and viral infections. So frequently for at least the first few months after transplant, and longer if there's graft versus host disease, kids will be getting IVIG infusion in the hospital about once a month. We can also see fungal infections in patients that have had a transplant, but thankfully the antifungals are significantly better than 10 or so years ago. So most patients will be on a drug called voriconazole or posaconazole to prevent fungal infections for about the first year after transplant. And patients will also be on a medication to prevent reactivations of herpes infections with a medicine as simple as Valtrex or acyclovir. So that's about graft versus host disease and infection. There's other side effects that around 6 or 12 months after transplant, once the main regimen-related complications are over, we really start to look carefully whether there's any evidence of these complications. And I'll go over some of them now. So 1, iron overload. So this can occur specifically in patients that have received a lot of red cell transfusions either before transplant or in the first few months after transplant. The red cells contain a lot of iron, and we know that these can build up in specific organs such as the liver and the heart, and over time, over years, can lead to organ damage. So we follow the ferritin levels pretty carefully, and if the ferritin level is elevated, we phlebotomize, or we essentially take out about 1 teaspoon per kilogram every month until we get that iron level below a specific threshold. Another late effect that's not uncommon is high blood pressure, specifically because patients have had toxicity to the kidneys from the preparative chemotherapy and from the immunosuppressive medication. So it would not be unusual for a patient to be on a blood pressure medicine for about 1 or 2 years after transplant. Kidney effects can also occur. This doesn't mean that it's going to severely affect the child. It's only very, very few patients that need something as intensive as dialysis, but it simply means that we monitor patients carefully with labs like BUN and creatinine and urinalyses, and do very frequent screening. And if there's a concern, we refer to the nephrologist or kidney doctors. We can have kidney injury because of infections that occurred during the transplant, because of a kidney injury related to the immunosuppressive medication, as well as a host of other factors. A small percent of patients also have some pulmonary complications. Again, some are not noticeable and may only be noticeable on a pulmonary function test, but a small percent of patients may have shortness of breath after transplant and need to be followed carefully with pulmonary. The major side effects that can lead to this would be the intensive chemotherapy and radiation given before transplant, or graft versus host disease that can, in a few patients, affect the lungs. We follow the heart pretty carefully with an echocardiogram every 6 to 12 months, and main risk factors for decreased ejection fraction would be significant exposure to chemotherapy or radiation before transplant. And so we do a lot of counseling in our long-term follow-up clinic to maintain a healthy lifestyle with exercise and diet. Metabolic syndrome is the manifestations are obesity, hypertension, high sugar, high lipids, and these patients are at higher risk for cardiovascular and cerebrovascular disease. And we know that transplant patients are at higher risk for this, and we follow them very carefully with lab work and with nutritional counseling post-transplant. We also follow in our long-term follow-up clinic endocrine-related effects and screen for growth hormone deficiency, screen for hypogonadism, low adrenal function, and low thyroid function. This is screened at least once a year post-transplant. Growth failure can be multifactorial. Often patients have been on steroids for many months to treat graft versus host disease, and especially if they're young, this can really affect their growth. And often we have to work very closely with endocrinology and prescribing growth hormone in some patients. This is a big concern for prospective transplant patients, which is the issue of ovarian failure, which is pretty high when patients are receiving a full intensity transplant preparative regimen. It is much lower when patients receive reduced intensity transplant regimen if their disease allows it. Reproductive issues are obviously a big concern, and they are directly related. The rates of infertility are directly related to the intensity of the preparative chemotherapy in boys and girls. So we see here, as we go from left to right, that the higher we go in intensity of a preparative regimen, unfortunately, the lower likelihood of a pregnancy and the lower rates of fertility that we have. So patients with leukemia that need a regimen that has very high doses of radiation would have a low likelihood of being able to get pregnant. This is very different in a patient with MDS or aplastic anemia that is able to receive a lower intensity regimen where the chances of fertility are higher post-transplant. Regardless of what type of regimen our patients receive, every patient receives and parents receive reproductive counseling to understand what the risk factors are and to understand what are the potential interventions. So in females that are prepubertal, we can do ovarian cryopreservation. In postpubertal females, we can do ovarian stimulation and harvesting. Similarly, in males that are of a young age, we can do testicular tissue harvesting. This is still considered experimental, but certainly in postpubertal males, the gold standard would be to do sperm banking. Osteopenia, osteoporosis, this is basically low bone mineral density, not uncommon after transplant. Nutrition has been affected. There's been a lot of inactivity and likelihood for low calcium and vitamin D intake. This is especially worse if patients have received a lot of corticosteroids for graft versus host disease. So kids get at 1 year and then yearly something called the DEXA scan to see what their bone density is, and if it is low, they're referred to endocrinology, and sometimes it's as simple as taking more calcium and vitamin D, but if there's very severe osteopenia, they could be candidates for medications that build up the bone called bisphosphonates. AVN or avascular necrosis. This is a difficult complication to treat that we don't see too often. It's mainly related to, again, corticosteroids that have been at high doses and for many, many months to treat graft versus host disease. And what can happen specifically in the big joints like the femur is a lot of damage to the vessels within those bones and defective bone repair. If patients present with specific pain in their knees or their hips, then typically we would get a MRI, and if there's changes suggestive of AVN, they would get referred to orthopedic surgery. Secondary malignancies. This basically means that patients are that have had transplant are at higher risk than a normal counterpart, than a typical person in that age group, for developing another type of a cancer, not the disorder for which they received a transplant. And this has to do with the intensity of the preparative regimen received. Sometimes things such as chronic graft versus host disease can also elevate the incidence of certain cancers. And they're listed here. Ocular complications. We sometimes have to work with our ophthalmology colleagues, given that some patients will develop dry eyes or keratoconjunctivitis. This is specifically related to graft versus host disease, and patients may need very frequent re-wetting drops, sometimes more intensive medicines, and patients can also develop cataracts. This would be typically related to the preparative regimen, the total body radiation, or the high doses of chemotherapy given. So we like to make sure that our kids see an ophthalmologist once a year, starting at the 1-year mark. Similarly, we like to make sure that kids follow up with dentistry once a month, given that there can be an increase in complications such as dry mouth and periodontal disease. Psychosocial complications can be higher after transplant, especially in patients that have had a lot of chronic conditions going on for a while post-transplant, such as chronic graft versus host disease. Some of these kids need to be on long-term immunosuppressive therapy. Some of these kids are coming to clinic frequently and not able to partake of school. So clearly there's a higher potential risk of psychosocial complications, such as depression, anxiety, and certain issues with cognition. So this was a very big list of potential complications. I think that centers are doing a much better job now than 5 or 10 years ago in identifying these complications before they become reach sort of they critically affect the patient. So we're doing a much better job screening for these complications in our long-term follow-up clinic, and identifying what patients need to be referred for specialty providers And most of the time, we're able to successfully do this before they reach a critical point, before the heart is very affected or the lungs are very affected. And we like to work very hard with our families. We like to work very hard with our whole care team, our social worker, our nurse coordinators, physicians, nurse practitioner, and really trying to transition these patients to a normal lifestyle as soon and as much as possible, knowing that we still need to be keeping a very close eye on these potential long-term complications. And this is just this is the last slide. This is just a reminder that there are a lot of resources for providers as well as for families these days with Be the Match, the Pediatric Blood and Marrow Consortium, Children's Oncology Group, a lot of ways that we're able to track the progress of our patients and families post transplant. So thank you very much, and I'm now open for questions.
Thank you, Dr. Jacobsohn, for the presentation. We have some questions. Our first question is, what is the incidence of developing autoimmune issues post-transplant if the original diagnosis was SCID or immune-related?
Okay, that's a really good question, and I'm not aware, Amanda, of any literature suggesting that the incidence is higher. Clearly, all patients that have had transplant are at a high risk of alloimmune complications such as graft versus host disease and low platelets because of immune dysregulation. But I'm not aware of patients with SCID, which is the severe combined immunodeficiency, or an autoimmune condition such as aplastic anemia having a higher risk of these complications post-transplant.
Thank you. Why is there an increased risk of GVHD if the transplant is female to male?
That's a good question, and the caveat is that it's really a higher risk if the donor is female and has had prior pregnancies. So it has to do with the immune system having been primed by the embryo and then reacting to the recipient once it's transplanted. So it's really females into males, but it's females that have had pregnancies, and the more pregnancies that have occurred, the higher the risk of chronic graft versus host disease in the recipient, in the male recipient.
Thank you. Do blood transfusions affect the success of a transplant?
Not really, no. The main, so blood transfusions are definitely necessary for a month and maybe longer to support the patient until the graft takes. I would say that they can affect the success of the transplant if a patient needs so many transfusions that they can get severe iron overload, for example. And that can begin to affect the organs such as the liver and the heart long term. But for the most typical patient, which needs about a month long of transfusions, it's generally not an issue.
Thank you. This question comes from a patient who is 5 years post-transplant and has had chronic graft versus host disease for 4 years. Is there any data on the lifespan of patients that have suffered complications in the first 3 years but do make it through?
I think, yes, I think that this is a really good question. I think that it really has to do with the severity of the chronic GVHD. So in general, if the chronic GVHD is mild and is not leading to, it's not impacting your activities of daily living and your quality of life, if the chronic GVHD is not needing a lot of immunosuppression, then the lifespan should be very very good, and we should not expect it to affect the long-term survival. However, for patients that have moderate or severe graft versus host disease and are needing significant amounts of immunosuppression, then these patients do have then it does affect their lifespan.
Thank you. Do you recommend being off immunosuppressive therapy before beginning vaccinations? If so, why?
This is a really good question, and I think the reason that you hear conflicting information is because there's different stylistic issues in different programs. Here, for the most part, we like to have patients off immunosuppression. However, if they have developed chronic GVHD and looks like they're going to be on immunosuppression for a while, in trying sort of to balance the risk of infection, we do try to vaccinate them and see if they respond to vaccinations. So for most patients, the answer is we try to have them off immunosuppression before starting vaccinations. But for a few patients, if it looks like they're going to be on some immunosuppression for years, we sort of try to look and see if they respond to try to protect them, since it's going to be a number of years that they could be susceptible to infection. I hope that answered your question.
Thank you. Is there any data on today's overall life expectancy of pediatric bone marrow transplant patients? Does it vary by diagnosis, such as aplastic anemia, MDS, or other malignancies?
It varies a lot by diagnosis. And, we can look at it varies a lot by diagnosis, and it varies a lot by stem cell source. So we can, for example, look at a patient with aplastic anemia that has a sibling transplant. The long-term outcome should be upwards of 95%. Similar for a patient with sickle cell anemia and an HLA identical sibling. However, once you're talking about patients with malignancies, specifically AML and ALL, the likelihood of survival long term is lower, somewhere in the 50 to 60% range. With regards to an MDS patient, it depends on a lot of factors: how long, how much chemotherapy the patient has received, whether they have specific chromosomal translocations, etc. But it would be probably somewhere in between a leukemia patient and an aplastic anemia, maybe somewhere in the 70–80% range.
Thank you. Are today's pediatric aplastic anemia transplant patients at significant risk of growth hormone deficiency?
I think it's really similar to other patients that have received a transplant for any other indication, and I think it's sort of more of case by case basis. If it's a patient that has received a lot of therapy for the graft versus host disease, they may be at higher risk. But if it's a patient that, for example, has not received any radiation before transplant, which most aplastic anemia patients don't, if it's a patient that has really sailed through and has not needed a lot of therapy for graft versus host disease, then I would not expect there to be a big concern for growth hormone deficiency.
Thank you. Does the onset of puberty have an impact on the timing of transplant?
It for the most part, no, because for the most of the time, most of the time we're doing a transplant. It's more dictated by the severity of disease and when we need to proceed. So we'll do reproductive counseling, and depending where they are, there may be different methods for fertility preservation, but we wouldn't necessarily change the timing.
Thank you. At what age is fertility preservation available in pediatric patients?
So it's available at all ages, and in the younger kids, prepubertal, so males, this is experimental, but males, they will offer testicular cryopreservation. So it's literally when the patient goes to the operating room to get a central line for another procedure, the urologist will do a biopsy of the testes, and that is stored long term and can potentially be used down the road. And similarly, in very young girls, even of a couple years of age, they can do ovarian tissue cryopreservation. Again, this is experimental, and there's not a lot of numbers as to how many of using this tissue led to pregnancies, but it is available. I think that another important answer to your question is that we're doing everything possible these days to try to reduce the intensity of the preparative regimen, so that it's not as toxic in general, and so that the rates and the incidence of infertility is not as high as they used to be. So a patient with aplastic anemia, for example, does not get the same preparative regimen as a patient with acute leukemia, where the incidence of infertility is is so high. So we would expect an aplastic anemia patient that is getting a regimen, for example, of cyclophosphamide and ATG, we would expect them to have a, we don't know what the rate of fertility down the road, but we hypothesize that it's a lot better than patients with leukemia getting very full intensity preparative regimens.
Thank you. If a female patient does decide to get pregnant after transplant, what are the risks?
I don't believe there's any specific risk to her or the baby, but I would have to look into this more. But my initial answer is that there's no specific risk to her or the baby, as far as I know.
Thank you. What is the risk of seeing GVHD when coming off immunosuppression?
Yeah, that's a really good question, and it's really dependent on whether acute graft versus host disease has occurred. So patients that have had acute GVHD are at much higher risk of developing chronic graft versus host disease once the immunosuppression starts coming off. So if a patient has not had acute GVHD, we expect the risk to be low. It's not zero, but it's certainly low to develop a graft versus host disease. Whereas a patient that has had severe acute GVHD, the incidence is quite high, that as you start tapering immunosuppression, you're going to start seeing reactivation of skin GVHD that's going to become chronic.
Thank you. If a transplant fails, can a child receive a second transplant? If so, are there additional risk of a second transplant?
Yeah, that's a really good question, and it can be very different depending. It can be very different depending on the scenario or the situation. So it's a little bit hard to answer. But in general, if patients need a second transplant very early on, so if patients need a second transplant within a few months of the initial transplant, then you worry a lot about the intensity of all of the therapy that's sort of being stacked within a few months. If it's 1 or 2 or 3 years later that a patient relapses and needs a second transplant, it's still a higher risk of complications than with the first transplant, but not necessarily as high as when the transplants are being done so close to each other.
Thank you. Is it better in the pediatric population to have a bone marrow transplant versus a peripheral stem cell transplant? If so, why? And is this the same for the adult population?
Well, that's a really good question. And we see a little bit of a difference between pediatric and adult practices as it relates to that question. We see much more use of bone marrow than peripheral blood in pediatrics. Bone marrow bone marrow recipients have a lower incidence of chronic graft versus host disease, which is one of the reasons we tend to prefer bone marrow versus peripheral blood. However, some of the issues, some of the cons compared to peripheral blood is that recipients of bone marrow can take a little bit longer to engraft. So maybe about 5 or 7 days longer. So for the most part, we're going to prefer bone marrow than peripheral blood in pediatrics, but there are a few cases where we may recommend peripheral blood. It may be related to how aggressive the leukemia is. Sometimes peripheral blood could potentially be associated with the higher graft versus leukemia effect, and sometimes there's such a major size differential where the donor is a lot smaller than the recipient, which makes obtaining bone marrow very difficult. So in that situation, we would probably opt for peripheral blood. So case by case, but most likely bone marrow in a pediatric program.
Thank you. If the transplant patient does not respond to immunosuppressive medications, is there another treatment?
So this is, you said if the transplant patient, so this is after the patient has received the transplant.
Yes, it says if the transplant patient does not respond to immunosuppressive medications, is there another option?
Yeah, so that's a good question. And here at the Children's and at some other transplant programs, there's a therapy called extracorporeal photopheresis. So this is a relatively novel therapy where the patient is hooked up to a machine that over the course of a few hours collects the blood, treats the white blood cells outside of the body, and then gives it back to the patient. It's sort of like a dialysis, but for white blood cells. And this is a pretty novel type of immunosuppression that has shown a lot of benefit in treating patients with graft versus host disease. So here, if patients are not responding to immunosuppression, we would introduce extracorporeal photopheresis. We don't do it in everyone because it's a treatment that we would do for many months.
Thank you. The decision to undergo a transplant can be a very difficult one for parents, for their child. Are there some key questions that parents should ask before making the decision to go to transplant?
Yes, I think that understanding, understanding the risk benefit is really important. So there are diseases where there's not a lot of choice. So a patient with a multiply relapsed acute leukemia doesn't have a lot of choice as they must go into transplant pretty quickly. It's different for non-malignant conditions. So patients with aplastic anemia, if there's not a perfect match, then a trial of immunosuppression may be warranted. So I think it's very disease specific and trying to understand from the transplant program what is the specific risk of of a transplant for my child, and how would the risk look like in the next few months or in the next few years if I didn't go through a transplant. And then in general, you know, one would want to make sure that when the family is looking for a transplant program, regardless of the condition for which they're being transplanted, that that they have a center that offers all of the supportive care needed, because actually delivering the transplant preparative regimen and delivering the stem cells is really easy. It's really what comes in the next few months, which is the supportive care of graft versus host disease, the supportive care of monitoring and treating all the different potential infections. It's really, really important to make sure that the family is comfortable that they have selected you know, a world-class center that's able to deal with all of these potential complications.
Well, thank you so much, Dr. Jacobsohn, for sharing your time and your expertise with all of us today. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes today's program. Thank you, Dr. Jacobsohn.
Thank you. It's been a pleasure. I look forward to doing it again.